Good afternoon, everyone. Sorry for this glitch. We had some logistic issues. I need to share my presentation. So, all right. So first of all, thank you for the Kuwait Neurology Conference organizers and the scientific committee. And also we thank Novartis for inviting me to present their symposium today. I'm going to talk mainly about some updates in the DMTs, but also I'm going to talk about why it is important to intervene early in MS. This is the agenda. I'm going to talk about some role of B cells in MS and also the difference between anti-CD20s. So first of all, we will agree that the damage that happens in MS starts very early in the disease, even sometimes at the RIS or CIS stages. So we need to preserve as much as we can earlier on. Also, there are lots of lesions happening in the MRI that probably we feel they are asymptomatic, but at the end, when they accumulate, they will affect the patient quality of life and well-being on the long term. According to the evidence that comes from multiple earlier studies and trials, early intervention, especially in those with highly active disease, probably gonna delay the progressive course because probably early inflammatory changes may lead to an increase in neurodegeneration with the long term. And we know that the inflammation of active lesion driven mainly by peripheral T and B cells. Most of the drugs do not go into the CNS. So we are mostly targeting the peripheral T and B cells, and that's our effective anti-inflammatory mechanism to prevent damage to CNS. Now, as MS progresses, there will be a central inflammation and neurodegeneration. And the issue with this is probably how we can target those. So probably we need to prevent central inflammation. And once it happens, then we have to think about a mechanism where a drug can enter the CNS in order to shut down the inflammatory process. So with this, once you have accumulation of disability, probably there's not much you're going to do. So you probably need to prevent it very early to preserve the brain function. And according to many studies, as you know, one of the milestones in MS patient is time to EDSS-3 or DSS disability scale of 6, where the patient is actually using a cane. So patient who had one relapse probably gonna go into EDSS within 22 years. However, if they have 2 relapses in first 2 years or 3 relapses or more on the first 2 years, you are pushing this very fast. So a patient may actually go to EDSS, i.e. having a cane in less than 15 years. So our target is very important early on the disease, and that's why we tell patients the first 2 years after diagnosis is a key for a long-term disability and also well-being. And this also appears with the MRI lesion load. If you have a small or a very low lesion load from the beginning, especially in the first 2 years, you're probably going to take more time to achieve the secondary progressive course or EDSS-6. However, if you have too many lesions, 3 or above, and sometimes we keep 7 or above, then we are talking about very highly active disease. You probably need to shut down this inflammatory lesion. Moreover, cortical lesions now appear more associated with an increased risk of secondary progressive course. And we all know all the trials of the CIS, where most CIS trials, if in the placebo arm, if you delay treatment for 2 years, they're not going to achieve the same response when it started early on. So time to EDSS, whether it's 4, 6, is actually very important. If you start a treatment within the first year, you're going to reduce the risk of progression by around 7% per year. to reach the EDSS-4. So once you delay it for 3 years, 4 years, you're talking about 15% or less of going into SPMS. So our key message is start early to delay the conversion to a progressive course. And this was seen also with the long-term trials, those with interferons or glutamate acetate. Those who start late actually cannot join the trend of the delay of SPMS in those who are on treatment. So the benefits associated with later treatment waned over time and disappeared by 8 years. So you probably need to go very fast earlier on. Now, high efficacy treatments been coming to the market since 2008. And historically, we always talk about escalations, and we go to a first line medication and second line medication. However, these kind of principles are not working for those patients with highly active disease or very aggressive patients. So now we are always talking about highly active therapies earlier on to initiate it in a patient who has the characteristics of highly active disease or aggressive disease. And this indeed will lower the risk of conversion to SPMS compared to those who go on start low or go slow. So this principle, the old school, is probably changing, and that's why we are going very aggressive in terms of treatment with MS patients. And one of the MS-based studies actually tried to assess the treatment with high efficacy medication compared to low efficacy medication. And in this trial, when they started patient with fingolimod, alemtuzumab, or natalizumab, they found a significant reduction in achieving the risk of conversion to SPMS when compared to first-line treatment. So even in those settings, we know high efficacy medication probably will reduce the risk no matter how. However, the risk is reduced more in those with highly active disease. So talking about mechanism of the pathogenesis of MS, we always talk about T cells. However, the B cells role has come into our insight in the last 10 years. And we all know that B cells are present in the periphery and also present in the CNS. And most of our targets usually is in the periphery, whether it's a bone marrow, lymph node, or a spleen, because it's not easy to actually target or enter the blood-brain barrier unless there is a significant inflammation where the blood-brain barrier may be open. And inside the CNS, the B cells are probably not easy to attract, and that's why it's not easy to eliminate all inflammatory cells in the CNS. So the target is actually mainly in the peripheral, because we think the pathogenesis of MS is actually inside to outside, or what we call from periphery to CNS. And we all know the function of B cells. I'm not going to talk about the pathophysiology of B cells. They present as an antigen, and they act as an antigen presenting cells, and they produce antibodies, cytokines, and also play a big role in the ectopic lymphoid structures. And there is some evidence in MS population where the B cell actually ruled in the pathogenesis. Most clearly, I think, is the oligoclonal band we find in the CSF of MS patient. This is an evidence of a B cell pathology. Also, when you use B cell depleting therapy like rituximab or ocrelizumab, we know that they are very effective. So we know the B cell rules actually there in MS patients. Now, when we talk about anti-CD20s, there are 3 types in the market, and actually more, but this is mostly, to MS, related to MS. We all know the rituximab, which is the chimeric form, and the humanized ocrelizumab, and the new drug ofatumumab, the fully humanized product. Now, the difference between rituximab and ocrelizumab and ofatumumab is actually the binding sites. Ofatumumab binds to 2 distinct non-continuous epitopes, which actually give rise to low off rate and also deliver potent and sustained effector activity. And ofatumumab is actually being tested in mice by 2 doses, the intravenous and the subcutaneous. And it was found that the subcutaneous administration goes directly to the lymph nodes and also spare the spleen. And this might be very important also for the depletion of B cells, because we are preserving the other organ B cells, which has some of the memory B cells. So more effective towards the lymph nodes when we talk about ofatumumab. And this cartoon shows you how B cells are rapidly depleted and repleted after you stop the subcutaneous ofatumumab in the lymph node. So that's one key mechanism of action of ofatumumab. And once you stop it or give the washout period, rapidly you will see the B cells are repleted. So this is a big difference when you compare it to other potent B cell depleting therapy, where it may take up to 6 months to have the cells repleted in the periphery. Finally, I'm going to talk about, I think this is the main clinical trial, SYMPOSIUM. It has 2 phase 3 trials, which led to the approval of ofatumumab for relapsing remitting MS. This is the study design. It is a placebo control, but in a way where there is a comparator arm. So the comparator arm is teriflunomide, and also the teriflunomide will receive the placebo ofatumumab, and the ofatumumab will receive the placebo teriflunomide. So it is a double-blind, double dummy with active comparator in a controlled parallel group. And it was a multi-center with a flexible design, because they have the outcome, primary outcome was time to the relapse. And so it was a maximum duration of up to 30 months in each arm. The comparator arm is teriflunomide 14 milligram once daily, plus the placebo subcutaneous, which is the placebo for ofatumumab. And ofatumumab was 20 milligram sub-Q, which was injected every 4 weeks after a loading doses for the first month with the 3 doses, plus the placebo oral. So if you look at the population here, we're talking about mainly relapsing remitting, age less than 15 with the EDSS up to 5.5. So we are picking some of the transitional patient with EDSS 4.55, but primarily you will see some of the progressive patient probably entering the study design based on the EDSS cutoff if they don't have a strict diagnosis of SPMS. And then there is the open label follow-up study for up to 5 years after the end of the actual phase 3 trial. This is the demographic and the baseline characteristics. And you can see the both SYMPOSIUM 1 and 2. There is no big difference between the treatment arm and the comparator arm, which is teriflunomide. If you look at the EDSS score, almost similar. If you look at the GAD enhancing lesions in both arms, almost similar. So there is no big difference. And also if you look at the age, so a little bit older than our population in the Middle East, where we have the mean age is around 27 to 30. But again, for the sake of the trial, both are the same into the arms. And this is the main outcome, and this is the primary outcome measure, which is the annualized relapse rate. And you can see there is a significant reduction in ofatumumab arm compared to teriflunomide. So bear in mind, this is not compared to placebo. This is compared to a first-line treatment. And as you know, most of the trials nowadays in the last 2-3 years, there is always a comparator arm. And in SYMPOSIUM 2, there is a almost 59% relative risk reduction of annualized relapse rate. So both trials were positive. So just to convert this number to a clinical number, we can tell patient, yes, there is a relapse and every 10 patient years. So maybe in 10 years of this patient, you may get a relapse. This is how the numbers are interpreted. And if you look at the secondary outcome measures, and the first one was the gut-enhancing lesions, and you can see almost suppression of inflammation of the MRI in both trials, probably better in the SYMPOSIUM 1. This is used, I mean, almost near completion of suppression, and this is seen across all the B-cell depleting therapy. And this is the number of new or enlarging lesions, again, similar to other studies. We are always talking about 80s. And I think this is one important outcome measure, which is the confirmed disability worsening at 3 months and 6 months. And again, the risk reduction between 32 to 34% over 6 months. So this is a very important message, is there is also a reduction in the disability progression over time, in the sustained, what we call, because 6 months is a probably sustained confirmed disability worsening. And as all other studies, we always do the post hoc analysis to assess the no evidence of disease activity, NEDA. And again, in ofatumumab arm in the first year is around 47% compared to 25% in the teriflunomide arm. And if you redo the analysis for the second year, this goes to 88%. And the NEDA is defined as no relapses, no MRI lesions, and no progression within the 6 months. So almost up to 9 out of 10 patients taking ofatumumab achieved NEDA in year 2. So just bear in mind, there is what we call reassessment of the NEDA in this trial after year 1. So rebasing after year 1. Safety, there is no any red flag so far. As expected, a slightly increase in injection reaction. I mean, this is a sub-Q drug with just minimal compared to the placebo arm of the sub-Q, but there is no other red flags in the actual adverse events, and there was no deaths or any serious adverse events that led to hospitalization or discontinuation. Now, for those who reported some injection site reaction, majority of them were mild and usually disappear by the 4th or 5th injection. And when we talk about mild, we are talking about grade 1 or grade 2, where it is only redness or itchiness or tenderness. But majority of those will actually resolve with time. So this is my end of the presentation, and I think we have 5 minutes for the questions. Thank you.